Hey guys, it's Dr. Buhler. I am recording this because I just tested positive for COVID, and my kids tell me that I am going to just get feeling worse and worse and worse. So I should record this now just in case I'm stuck under the covers in bed for the next couple of days. So forgive me if this sounds like somebody who's massively ill is lecturing to you, because that is what it is. So we want to start by talking about depression and what the disease is and what causes it, and then the pharmacology of antidepressant drugs. I have some pre-class materials here for you, some terminology and abbreviations. Sometimes it's good to just read that through before you do a lecture. And these are the drugs on my drug list. Here it says you're responsible for the bolded drugs. We're going to talk to Dr. Markova and see what she says about the other drugs, the ones in italics, and whether those are you're also going to be responsible for those. So at this point, assume that you know you're going to be responsible for the bolded ones, and you're probably going to end up being responsible for the other ones. So just some roadmaps, so you can read it ahead and kind of see what we're doing. Basically, the big picture is that we've got mood disorders and we've got anxiety. And mood disorders include depression and bipolar disorder, and anxiety is just kind of an anxious feeling on top of that. Like you can be anxious and depressed, or you can be anxious and not depressed. So that's not considered mood disorders. And the term depression, people use that all the time. I'm depressed. And that's fine. We can use that terminology, but we need to know that that's very, very different than what we call major depressive disorder. One of the main things that we understand about mood disorders, or specifically depression, is that we think there's a decrease in monoamine levels. That's serotonin, norepinephrine, and dopamine in particular brain regions. And that can be a cause, or at least a component of the cause, for depression. And so because when we look at people with depression, we see low serotonin levels. When we look at genes for people and families with depression, we see changes in gene expression or changes in DNA in serotonin and monoamine, all the components of those pathways. And because the drugs that we've used have been those that increase monoamine levels, specifically serotonin, then our pharmacology is really going to be focusing on increased monoamines and specifically increased serotonin levels. So those antidepressants, as I said, are going to act by increasing these monoamines, some combination of them. We don't use agonists at these. We either block the breakdown or block the reuptake. And so when we talk about monoamine oxidase antidepressants, those are going to block the breakdown of all the monoamines. Newer antidepressants block the reuptake of different monoamines. And we try to be as selective as we can, like, can I block dopamine reuptake or can I block serotonin reuptake? But still, we can't just block one without blocking others. So these guys are always dirty drugs, which means they act at a lot of different pathways and receptors, even that we don't want. It's got the learning objectives. And we're going to talk about mood disorders, types of mood, pathophys of depression, and monoamines. So a good thing to talk about when you're starting into this topic is neuropsychiatric disorders. And a lot of people make a distinction between neurology and neurological disorders, or psychiatric disorders in psychiatry. And to be honest, there is no distinction. The only thing that's different is basically how much we understand about it. Epilepsy used to be considered a psychiatric disorder, and then it became a neurological disorder because we finally understood what was going on and causing symptoms. So when we look at things that we think of as neurological disorders, they almost always have some psychiatric component, like Alzheimer's, we think of as neurological? Well, it's got psychiatric mood components. Schizophrenia, we think of as psychiatric, it's got movement and motor components. So the big ones that I want to kind of point out to you, just so you kind of see where we are, is that we can have disorders that are fairly simple neurotransmitter level misbalances. And it's obviously not that simple. There's still a lot going on. But if you can say this disorder means you just have low serotonin or you need more glutamate or whatever, that's a lot easier to treat. If you can just say, okay, I'm going to up this and down that. The next type are neurodegenerative disorders, and those are a lot tougher because if you have death of certain neurons in certain pathways over time, you can't really bring those neurons back. And usually you don't see that those neurons have died until you already have enough damage that you have symptoms enough that you're going in for it. And by that time, there's a lot of cell death already occurring. So what we want to do there is right now, we're trying to boost that function of any of the neurons that are still there. But what we really need to do is figure out how to keep them from dying. And then the third type of neurodevelopmental differences, or what we call them, and with things like autism and schizophrenia, where it's not neurodegenerative, neurotransmitter balances are fine, but you just made different firing pathways. So, when you have a connection from one area of your brain to another, it can be neuroatypical, in which that connection isn't made the same way in someone with autism. So when we look at these and we talk about neuropsych disorders, the way that we're going to need to treat a disorder is really different depending on what type it is. So I mentioned that anxiety and mood disorders are what we're going to be talking about. We're going to start with mood disorders, which include depressive and bipolar. And we can say mood in a couple of different ways. We can say your mood state, which is what's your current mood? I'm happy, I'm sad, I'm frustrated. That's fine. You have a mood state at all times. It's not the same as a mood disorder. And so if you have a depressive mood disorder, that's something that it's not just for a short period of time, and it's not something that you can kind of shake off. So we need to really realize when we talk about mood that mood states and mood disorders are very different. You're also going to be hearing about anxiety disorders, and I have the DSM-5. And what the DSM-5 is, if you're not aware of it, is the Diagnostic Statistical Manual number 5, and it is the psychiatric manual that all psychiatrists use to diagnose. And you can go to it, you can look online, and it has for every psychiatric disorder the exact checklist of the symptoms you would have to have. And so there's a lot of different subtypes of anxiety disorder. Generalized anxiety disorder is actually fairly common. Panic disorder, social phobias, and there's a lot of other ones that we can talk about when we actually talk about anxiety disorders in more detail. So when we talk about mood states, remember mood states were not the same as mood disorders. So a mood state is just your normal mood. Sometimes people call mood affect, just kind of how you're feeling. And so normal mood or normal affect is just euthymia. And it means you're just going along basically just all right. Here's euthymia. The U is just going along, no problems, no ups, no downs. You're just where you're supposed to be. If something really terrible, sad happened to you, your pet died, that's going to cause low mood or low affect, and you can have depression as a mood state. And you can have dysthymia, which is kind of a lower form of sadness and low energy and apathy, but it doesn't actually turn into clinical or major depression unless you have it come way down and have some of the symptoms are shown in the DSM, which are going to include things like no energy, distorted thinking, things that are actually really different than just feeling bad or feeling blue. And then you've got the high or elevated mood or affect. And everyone can have some happy, elevated mood. That's always good. Usually we enjoy that. And hypomania would be a fairly non problematic kind of increase in energy and I'm going to go do this. This is great. You can irritate other people. And you can become irritable as well. But that's still just, that's not clinically relevant. That's not something that would cause a problem for someone. Someone with bipolar may hit mania, which really is something that is clinically problematic for them and harms them. And you'll talk with Dr. Beggert about bipolar and talk a lot more about mania and bipolar depression. So those were the mood states. When we talked about euthymia was a mood state, you can feel depressed, you can feel euthymic, you can feel happy, hypomanic. But the mood disorders are unipolar depression and bipolar. And really, unipolar depression means that you're going along, you have kind of a mood state, and then when you go into a depressive episode, it goes down. And when it gets better, it comes back to around its baseline. And then bipolar is when you have a mood state and it really like can go oscillate between mania and depression. And even though I'm drawing it like this, there's no hard and fast rule that mania goes before depression or anything like that. So hopefully that kind of gave you an idea of what mood disorders are, how they differ from mood states, and how that differs from anxiety. So there's a lot of types of depression, and people often don't really clarify that because we kind of as a society talk about depression as if it's one thing. And often if we're someone who has a family or friend or yourself that has depression, may not recognize there are these different types. So the types of depression we have are major depression, and that kind of just sticks with you all the time. It's a depression that it's not caused by anything. It's just there and it's over a long period of time and it takes you out and it makes you really impacts and impairs your life. We've got persistent depressive disorder, which is also persistent, but it is less severe than major depression. So when we called this formerly dysthymia, was low mood disorder rather than really serious. We've got seasonal affective disorder. People that live in Oregon know what that is often. Got psychotic depression. Sometimes people with depression can have psychosis, can have beliefs of things that aren't true, or can have hallucinations. We've got postpartum depression and peripartum, and premenstrual dysphoric disorder. You're going to see that when we look at anxiety, you're going to have these same 4 quadrants. And when we look at the symptoms of depression, we've got emotional symptoms, behavioral symptoms, thoughts, and physical symptoms. So one of the great ways to memorize this is SIG caps or SIG caps. So you've got sleep changes. That's a physical symptom. You've got a loss of interest in activities. That would be an emotional or thought. Some of these are kind of hard to distinguish exactly which quadrant it's in. Can have feelings of guilt, can have low energy or fatigue, diminished concentration, usually decreased appetite, but sometimes people have weight gain, but most people have diminished appetite. Psychomotor really just means like if you the best way I can do it is give an example of someone who is in a major depression and they're sitting on the couch and you're like, okay, come on, we need to go out. Let's go out and go to the store. And they're just like, I can't move. I'm not motivated. I can't move even if I want to go. I just can't seem to get myself up. Those types of things are that slowing of your movements. And then the opposite is if someone just becomes agitated during their depression. And then, most severely, thoughts of suicide and thoughts of death or suicidal ideation. And ideation is an important word to know because ideation is thoughts. So we talk about suicidal ideation if people are thinking about it versus suicide attempts. And a lot more people have ideation than have attempts. So it's pretty important to recognize that. So, yeah, so when you have something going on in your brain, it's not going to just hit one thing. Like, depression is not just going to be emotional, it's going to affect your cognition, it's going to affect how you use your body and what it's capable of doing, and it's going to affect the things that you do. So, we're going to talk about causes of depression. This has been looked at for years and decades, and we actually do know a lot about it. The more we know, the more things we realize that there's something else we'd never looked at. So even though we know so much more, it just seems like we have not gotten closer to an answer. But there are a lot of really clear risk factors, and genetics is about 50% of the risk factor. So it obviously runs in families, genetically, but we've also got a lot that's not due to the genetics itself. And we can talk about epigenetics as we go. But one of the things I kind of alluded to was when they then look at the genes, they get these families where multiple people have major depression and multiple people don't. And then they look and see, get DNA from all of them and see what's in common with the people that have depression. They find a lot of different kinds of genes, but they all seem to kind of come in to those monoamine signaling, to function of synapses, and to general health of cells and division of cells. So when we look at those, it's kind of a mix and match. You don't Not everybody has the same combination of those things. It's just if you get enough of these and enough of those, it could kind of tip you over the border into something that is actually going to be problematic for you. We know that women are much more likely, twice as likely, to have depression. And when I'm saying female sex here, we're talking XX chromosome. Childhood trauma has a huge effect on it. And a lot of times back in the olden days, right, people were like, oh, well, if you had trauma as a child, then you don't know how to, like, it just messed up your brain and you're neurotic or whatever. And now, of course, we're looking at that a lot more detailed and a lot more subtly. And yes, having trauma, you can be in a situation where you don't learn coping techniques. That is absolutely a case. But we also see that trauma in childhood changes the way your genes express themselves. And so we have epigenetics, which is you have the same DNA, but you're expressing at higher or lower levels or different combinations. So even with the same DNA, you're getting completely different signaling and different neuron activity. And then we have environment. You can have a risk for depression in your family. You can have other risk factors, but things like current stress levels, to other disease, other medications can really add to that burden and be a risk factor. So that theory of depression, that monoamine imbalance, when we talked about monoamines, remember we talked about serotonin, norepinephrine, and dopamine. And that original OG theory was the monoamine theory of depression. And right now, there's so many detailed little offshoots of this, and you could go into them, each offshoot for an entire career. But what you're going to come back to, if you have to kind of put everything back into one little bag, is not having enough serotonin, norepinephrine, and maybe sometimes not having enough dopamine. And so that's when we talk about not having enough of a neurotransmitter, you don't just not have enough in every area of your brain, because every neuron is and tissue type is expressing differently. It's under different control. So if we're talking about not having enough serotonin for depression, we're saying, oh, you don't have enough in your cognitive regions, your reward regions, or your emotion regions. That doesn't mean you don't have enough serotonin somewhere else. So drugs are pretty troublesome because when we put that drug in you, it affects everything everywhere. And so an SSRI we'll talk about is going to increase serotonin levels in every single part of your brain. But the disease only decreased it in a few. So you might be normalizing some of the decreased levels, but then you're going to cause adverse effects by raising it everywhere else. So every time that we talk about using a drug in order to normalize a certain pathway, whether it's depression or epilepsy or birth control, like anytime you do that, you have to really realize that every pathway and cell type is going to respond a little differently. So the original theory was just, oh, your brain doesn't have enough monoamines in these three regions. And because it doesn't have enough in these three regions, you're going to have problems with depressed emotion. You're going to have slowing of cognitive pathways and trouble keeping up and trouble thinking ahead. And you're going to have decreased pleasure or reward. And if you don't get reward from doing it, like if usually you go out biking with your friend and then afterwards you get an ice cream and it just makes you feel great every time you do that every Sunday, well, now that reward pathway is not even working. So your friend could get you to go out and do it, but it just doesn't feel good anymore. So it's going to be pretty hard to get motivation up to do that if you're depressed and you're having psychomotor difficulty initiating actions, and then you don't have a lot of reward. So this all looked really great. And then the big question, though, still hangs over it, which is when you start taking an antidepressant, it usually takes several weeks to see the effect. And that makes no sense if you're saying, okay, here I've got a little synapse, it's serotonergic. I'm saying that we don't have enough serotonin. Then I give a drug that's going to increase serotonin. That should just act immediately. Like as soon as that drug level goes up in my body, I should have that serotonin. I should be okay. And it doesn't. So what that says is there has got to be something different going on here. So that clinical delay says that, yes, the mechanism of the action at the enzyme or at the receptor or wherever that drug is acting at is what we say it is, because we know molecularly that's what it does. But we also know that it's got to be making downstream changes. And those downstream changes have to be coming in over a week, 2 weeks, 3 weeks. And if you ask a neuroscientist what could cause long-term changes, they're going to take weeks to occur. Well, we're going to say, oh, you could up or down regulate receptors. You could change the number or strength of synapses. So we're going to be looking at all these really interesting ways that a cell can, or a neuron can remodel itself and remodel its connections in order to make up for that. We are not going to go into any of the 1,000 theories of what is going on with regulation and plasticity, because honestly, there's a lot of great ideas out there. None of them are accepted as the truth. And when it comes down to it, thinking about this as you want to raise monoamine levels, but it's going to take a little while, ends up really being what you have to work with. So I've got a couple questions here, and I'm going to post a key. And we're going to talk about monoamines.